Hey there, CyberMDs, and welcome to another lecture. Today we'll be covering gallstone pathologies as they apply to the USMLE STEP 2 exam. Please remember to subscribe and leave us some feedback so that we can continue to provide free medical education resources for students all around the world. Let's get started. On this slide, you can see that there's a background of the etiology of the diseases that we will be discussing. Remember that there are three types of gallstones. The first is cholesterol stones, which typically are yellow, and those are going to form whenever bile becomes saturated with cholesterol. We can also get black pigment stones, which typically occur secondary to hemolysis, and those are going to consist mostly of calcium bilirubinate. And then finally, we can get brown pigment stones, and those are often going to be secondary to some sort of bacterial or parasitic infection inside of the biliary tract itself. With regards to risk factors for gallstone disease, the most famous mnemonic is going to be the 4Fs mnemonic, which stands for fat, female, fertile, and 40. Some people like to add a fifth F, which stands for fair, and this is to remind people that the Caucasian population is at an increased risk for developing gallstone disease. What this mnemonic means is that patients who are female, or obese, or pregnant, or have been pregnant, and are near their 40s in age, are all at higher risk for developing symptomatic gallstone disease. With regards to the fifth F, being fair, it is true that Caucasians are at a higher risk for developing gallstone disease. However, it is worth noting that Native Americans and Hispanic populations are also at an increased risk. Risk factors such as diabetes, dyslipidemia, and rapid weight loss may also play a role in the development of gallstones. Other risk factors and medications that can contribute to the development of biliary disease are listed on the right side of this slide. Be sure to review their mechanisms of action, as test writers tend to go for some of these risk factors in the question stems. In my personal experiences, again, this is anecdotal, Crohn's disease, prolonged fasting, and extended use of TPN, as well as use of estrogen therapy, are all highly tested and relatively high yield and worth knowing. Review the mechanisms by which these increase the risk separately from this lecture. Now, throughout the duration of this lecture, we'll be following the gallstones as they move from the gallbladder and they progress in a journey throughout the body to cause different symptoms and different findings at various anatomic locations. The first diagnosis is going to be, in this progression, is going to be Cholecystitis. Sometimes it's simply referred to as Cholelithiasis. In Cholecystitis, the patient, or Cholelithiasis, the patient is asymptomatic. They have no physical exam findings because the gallstones are not yet creating any issues in their body. Therefore, the diagnosis is typically going to be made incidentally, usually with an ultrasound or a CT scan. There is no treatment as, again, the patient is asymptomatic, and their laboratory findings should all be within normal limits unless there is some other pathology causing a disturbance in those labs. On this slide, you can see the video on the left of gallstones on ultrasound, and on the right, you can see gallstones on CT imaging. Now, the next diagnosis in this lecture is biliary colic. Biliary colic describes a pain that comes and goes in our patients. This pain occurs as the patient's gallbladder attempts to squeeze out bile. However, the cystic duct, becomes obstructed by gallstones. As the gallbladder continues to contract against the obstruction, the pressure inside the gallbladder is going to increase and cause pain. As the gallbladder relaxes, the pain subsides and the stone will move out of the cystic duct and fall back into the body of the gallbladder. Typically, patients do not present to the emergency department for biliary colic. However, this is something you may encounter during your practice as a physician. Patients with biliary colic often experience right upper quadrant pain whenever they have a very fatty meal. These episodes of pain can last anywhere from 30 minutes to 6 hours. However, it's most typical for that pain to peak within 1 hour of the onset of the meal and then begin to subside afterwards. On physical exam, patients with biliary colic will generally be well appearing and have a very benign abdominal exam. However, some patients may have some voluntary guarding as they are nervous about the reproduction of that pain that they were feeling. Because the obstruction comes and goes, there is unlikely to be any derangements in the patient's laboratory findings. This may be diagnosed with a right upper quadrant ultrasound in combination with the patient's history. With that being said, patients with biliary colic typically do not present to an emergency department where they may receive this workup. These patients can primarily be managed with a low-fat diet, over-the-counter pain control such as Tylenol or ibuprofen, as well as some antiemetics. With that being said, the patient may also optionally have an outpatient cholecystectomy in order to remove their gallbladder before the gallstones can begin to cause pathology that could develop into something serious or life-threatening. Patients may also receive a medication called ursodeoxycholic acid, which works to decrease the saturation of cholesterol within the bile itself. As the stone progresses forward, it becomes permanently lodged in the cystic duct, causing an obstruction. This is the cause of acute cholecystitis. There are some studies that suggest that this alone is not enough to create the presentation of acute cholecystitis in our patients, and that a second irritant is going to be required. This is beyond the scope of step 2. The thing to remember is that the most widely accepted understanding of this pathology is the permanent obstruction in the cystic duct. When the cystic duct becomes permanently obstructed, the gallbladder squeezes against the obstruction, which increases the pressure, and with permanent obstruction, over time, the gallbladder expands and the pressure eventually is going to cause ischemia. Without treatment, this can lead to histologic changes such as edema, necrosis, and gangrene. These patients often have abdominal pain that is primarily in the right upper quadrant, but may also be in the epigastric area. The pain is typically steady and may radiate to the patient's back or the right shoulder. Common historical symptoms often include nausea, vomiting, anorexia, which is decreased PO intake, and sometimes fever. There may be a history of a meal consisting of fatty food within an hour of the onset of the pain that the patient is presenting for. On physical exam, findings can include tachycardia and fever, and the patients may sometimes be generally ill-appearing. The inflammation of the gallbladder wall can irritate the peritoneum in the surrounding area, meaning the pain may be worsened with movement such as bed shaking or walking or jumping up and down. There is typically some form of guarding, and you should always check for a Murphy sign in your physical exam. To perform this, the patient must take in a deep breath as you palpate the area just below the liver's edge. The irritation of the peritoneum and gallbladder with palpation will cause inspiratory arrest, where the patient catches their breath during the maneuver. Alternatively, a sonographic Murphy's may be performed where pressure is applied to the gallbladder under direct visualization on point-of-care ultrasound. In the patient's workup, there may be a leukocytosis with or without a left shift. Alkaline phosphatase and bilirubin levels are typically going to be within normal limits. Elevations in AST and ALT would only be seen much later in disease progression as the inflammation from the gallbladder wall begins to irritate the hepatocytes next door. Remember that AST and ALT come from the liver, while bilirubin is conjugated there, and that there's also alkaline phosphatase activity there. This obstruction in the neck of the gallbladder does not cause any backup of flow from the liver into the biliary system, so there are no changes typically seen in these labs. With regards to obtaining the diagnosis itself, physical exam and labs are not enough. Typically, a right upper quadrant ultrasound is the first step in the diagnostic approach. And what confirms the diagnosis is gallbladder wall thickening and or gallbladder edema, also known as pericholecystic fluid. You can also sometimes see the stone lodged in the cystic duct on ultrasound, giving you your definitive diagnosis as well. If this fails, you can attempt to make the diagnosis with a HIDA scan. HIDA scan stands for hepatobiliary aminiodiacetic acid scan. It's also known as cholecystography or hepatobiliary scintigraphy. In this scan, a radioactive tracer is injected into the bloodstream, and subsequent imaging allows for visualization of the biliary tree. If the cystic duct is obstructed, the gallbladder itself will not fill with the dye. For me, I always remembered this by saying to myself that if the right upper quadrant ultrasound is negative and you think there is a stone hiding in the cystic duct, get a HIDA scan. If clinical suspicion remains extremely high after a negative right upper quadrant ultrasound and after a negative HIDA scan, then you can obtain CT and or an MRCP, and these are other options that are, again, typically used to rule out other diagnoses, but can be used in this situation after you've obtained a right upper quadrant ultrasound and a HIDA scan. So now the question becomes, what do we want to do about it? Well, we're going to want to help the patient with their pain, but we also want to provide antibiotic coverage for gram-negatives as well as anaerobes. These are all of the same bugs that occur in the GI tract. So for anaerobic coverage, we'll often use metronidazole, and for our gram-negative coverage, we can use ciprofloxacin or ampicillin plus gentamicin. So those combinations, again, is metronidazole plus ciprofloxacin or metronidazole plus ampicillin plus gentamicin. Lastly, that gallbladder has to come out, and so urgent cholecystectomy is recommended because the patient may become septic if left untreated, as the gallbladder can perforate with that increased pressure, leading to peritonitis and further complications such as gangrene, which may present with an emphysematous gallbladder due to the gas-producing bacteria. One thing worth mentioning, there's a special diagnosis known as mirizzi syndrome, and it's very similar to acute cholecystitis. However, in mirizzi syndrome, the obstructing stone in the cystic duct also places pressure on the common hepatic duct, causing obstruction of the common hepatic duct as well. The primary findings that indicate this diagnosis are going to include elevations in AST and ALT, ALK Phos, and bilirubin, but the imaging is going to be consistent with acute cholecystitis rather than with some other diagnosis. So on the left of this slide, you can see a stone in the gallbladder, but importantly, whenever it swaps to long axis on this ultrasound, you can see the stone lodged in the cystic duct of the gallbladder itself. And then on the right, you can see an ultrasound of the gallbladder, which has become gangrenous and has the twinkling lines that sometimes indicate small bubbles of gas or air on ultrasound. And then lastly, on this slide, you can see a normal HIDA scan. Again, this is a normal HIDA scan with the structures labeled. In acute cholecystitis, you wouldn't see the gallbladder filled with the tracer because that stone is obstructing the gallbladder from becoming filled with the tracer. Next in our list of diagnoses, the stone may have moved beyond the cystic duct and is now lodged in the common bile duct. This is known as Choledocholithiasis. The symptoms are much of the same with right upper quadrant or epigastric pain. There may be nausea, vomiting, and anorexia. On physical exam, the patient may appear jaundiced and have a palpable gallbladder, known as Courvoisier's sign. This gallbladder becomes palpable because it has become so dilated due to the obstruction. While patients will often present very similarly to acute cholecystitis, their workup will reveal what is referred to as a cholestatic pattern, meaning that the bilirubin and ALK Phos levels will be elevated due to that obstruction in the common bile duct. You may also see some elevations in the LFTs as well, so AST and ALT. Remember, we talked about these markers coming from the liver, and so an obstruction in the CBD causes backup into not only the gallbladder, but also into the liver. Initially, these patients will receive a right upper quadrant ultrasound, typically looking for signs of acute cholecystitis. However, on that ultrasound, there may be no signs of acute cholecystitis and no signs of stones in the gallbladder or in the cystic duct. Alternatively, though, there may be signs of a dilated common bile duct, which would increase your suspicion for some sort of obstruction in the common bile duct itself. Therefore, you would obtain an MRCP to make the diagnosis. MRCP stands for magnetic cholangiopancreatography. For all intents and purposes, it's a very specialized MRI that looks at the gallbladder and bile ducts. Again, the question becomes, what do we do about it? And again, we're going to want to help the patient with their pain, and we also want to provide antibiotic coverage for gram-negatives as well as anaerobes. We'll again use metronidazole for anaerobic coverage, and for our gram-negative coverage, we can either use ciprofloxacin alone or ampicillin in combination with gentamicin. Lastly, the stone, the source of our problems, has to come out. We get the stone using something known as ERCP. This stands for endoscopic retrograde cholangiopancreatography. In this procedure, a tube with a video camera, known as an endoscope, is placed in the GI tract, and contrast dye with X-rays allows the physician to visualize the stones. A lot of these abbreviations can be confusing, so to keep it straight, I remember that MRCP makes the diagnosis of choledocholithiasis, while ERCP extracts the stone. And of course, if left untreated, this choledocholithiasis, this pathology, can lead to acute cholangitis or gallstone pancreatitis, both of which will be discussed later. On this slide, on the left, you can see ERCP, which is going to be showing those stones in the common bile duct via fluoroscopy. And then on the right, you can see the MRI showing stones inside of the common bile duct as well. So next up, the stone has progressed through the common bile duct and is now obstructing both the common bile duct and the pancreatic duct. This is known as gallstone pancreatitis. Again, the symptoms are much of the same, with right upper quadrant and or epigastric pain, nausea, vomiting, and maybe some anorexia. On physical exam, the patient may appear jaundiced and have a palpable gallbladder. However, because the pancreas is now involved, there may be signs and symptoms of pancreatitis in addition to this CBD obstruction. The workup will consist of findings similar to that of choledocholithiasis. However, the lipase and amylase will likely be increased in addition to the liver enzymes bilirubin and ALK-Phos levels. As always, what do we want to do about it? Again, we want to help the patient with their pain, and we also want to provide some antibiotic coverage for gram-negatives as well as anaerobes. We'll again use metronidazole for our anaerobes, and then for our gram-negatives, we can still use ciprofloxacin alone or a combination of ampicillin and gentamicin. Again, the stone is the source of our problems, and it has to come out. We get the stone out using ERCP. ERCP in these particular patients is both diagnostic and curative. However, to proceed to ERCP without first performing MRCP, there must be evidence of common bile duct obstruction, which is typically seen on ultrasound. So, get a right upper quadrant ultrasound looking for CBD dilation. This doesn't confirm the diagnosis, but if dilation is present, then you can proceed to ERCP. If there is no dilation, then perform MRCP or an endoscopic ultrasound to confirm the diagnosis. Remember, ERCP is both curative and makes the definitive diagnosis in patients with gallstone pancreatitis. And then something called percutaneous drainage, where they go in through the skin and drain the gallbladder using a tube that they placed again through the skin. This can be used to buy you some time in these patients and relieve some of the issues while you figure out what's going on. The next three diagnoses are slightly different from the previous progression of a gallstone through the biliary tract. In the first of these, which is acute ascending cholangitis, there is a biliary obstruction of some kind that allows for the spread of bacteria from the duodenum into the biliary tract. The obstruction allows bacteria to ascend from the duodenum through the sphincter of Oddi and into the biliary tract. This may be due to sphincter of Oddi dysfunction, foreign bodies, gallstones, or cholestasis. The most classic description of the presentation of patients with acute ascending cholangitis is known as Charcot's triad, which includes fever, abdominal pain, and jaundice. These findings are not present in all patients, but it is worth noting that this is the classic description and that you should look out for this constellation of symptoms. Additionally, patients who are further in the disease process may present with something known as Raynaud's pentad. This includes the aforementioned fever, abdominal pain, and jaundice, but also includes hypotension and altered mental status. Essentially, these patients are in septic shock. If these patients come in and they have abnormal liver tests with Charcot's triad, you can proceed directly to ERCP, which will both confirm the diagnosis and also relieve any obstruction to provide some drainage. In every other patient, you will get a right upper quadrant ultrasound looking for signs of obstruction, and this will be followed by a CT scan if the ultrasound is negative. The CT scan can provide diagnostic information and also rules out a bunch of other life-threatening diagnoses. If the CT scan is negative, you can proceed to an MRCP. Once the obstruction is removed and the diagnosis is made, the patient can get a cholecystectomy once they are stabilized. While all of this is going on, they will receive the same antibiotics that we have been discussing throughout the lecture. Provide antibiotic coverage for gram-negatives as well as anaerobes. We'll again use metronidazole for our anaerobes, and then again for gram-negatives, we can either use ciprofloxacin alone or a combination of ampicillin and gentamicin. Gallstone ileus is the next topic of discussion, and while it does not cause the typical pattern of disease that we've been discussing, it does create a mechanical bowel obstruction. In this disease, chronic inflammation of the gallbladder allows for the formation of a fistula between the gallbladder and the small intestine. Stones then pass through the fistula and progress through the small bowel to the ileocecal valve, at which point, if they are large enough, the stone will obstruct that valve opening. The patients present with vomiting and a diffuse abdominal pain. On exam, they are often dehydrated and are possibly febrile as well. They may have signs and symptoms of acute cholecystitis as well as the signs of their bowel obstruction. With regards to a laboratory workup, they may have a leukocytosis or electrolyte abnormalities secondary to the aforementioned dehydration. Because there is a chronic irritation of the gallbladder next to the liver, you may also see elevated AST and ALT. A CT scan is the most widely used imaging modality to confirm this diagnosis. On a CT scan, patients will often have thickening of the wall of the gallbladder, intestinal obstruction, and the obstructing gallstone, and importantly, pneumobilia. Pneumobilia, which is air in the biliary tract, is an important finding as it shows that the air from the GI tract now has a way to enter the biliary tract due to the formation of that fistula. These patients often receive surgical intervention to remove that obstructing stone. On this slide, you can see a CT scan showing that pneumobilia that I was just talking about, which would make you suspicious for gallstone ileus or some sort of biliary tract perforation. The final diagnosis that we will be discussing in this lecture is Acalculous cholecystitis, which means cholecystitis but without any stones. This disease process occurs secondary to gallbladder stasis and subsequent ischemia due to the buildup of what is often referred to as sludge in the biliary tract. Patients have variable presentations but may have fever, jaundice, they may be a septic workup, and they may even be in shock. Lab findings will often include a leukocytosis, abnormal LFTs, increased bilirubin, and an increased alkaline phosphatase. Patients will typically receive an initial ultrasound if they have right upper quadrant pain. CT scan is typically second line as symptoms of biliary or even bowel obstruction may be present. Occasionally, a HIDA scan is obtained if the presentation fits more closely with acute cholecystitis. Remember, our patients don't always read the textbook, so the presentation can be variable. All of the results combined with the clinical picture make the diagnosis. As far as treatment goes, if they have gallbladder necrosis, emphysematous gallbladder, or gallbladder perforation secondary to the acalculous cholecystitis, then an emergency cholecystectomy must be performed. Otherwise, percutaneous drainage of the gallbladder is typically the management option chosen. We'll also still be controlling their pain and providing them with metronidazole in conjunction with either ciprofloxacin alone or ampicillin and gentamicin combined. Lastly, let's briefly discuss a differential diagnosis for abdominal pain. Can't miss diagnoses include the Barf-Oates mnemonic, which stands for bowel obstruction, appendicitis, AAA, ruptured ectopic, free air, which reminds you to think about perforated bowel, ovarian torsion, acute mesenteric ischemia, and testicular torsion. Other diagnoses that you can consider for common etiologies of abdominal pain include abscess, gastritis, gastroenteritis, hepatitis, pyelonephritis or a UTI, pancreatitis, and peptic ulcer disease. I think it's important to rule out the Barf-Oates diagnosis before moving on to a differential diagnosis that is quadrant-based, but these are all diagnoses to consider in any patient with abdominal pain, and your history, physical, and overall approach should reflect that you considered, ruled out, or need to rule out each of these life-threatening and or common diagnoses. Lastly, remember that your patients don't read the textbooks, and that right lower quadrant pain or generalized abdominal pain doesn't entirely rule out gallstones, although it may decrease your clinical suspicion initially, especially if the history is inconsistent with gallstone disease. On this slide, I've simply put a recap of what we have covered so far, which can also be found in the review sheet linked in the video. So, thanks for tuning in, and please remember to subscribe and drop us some feedback so that we can continue to improve and provide free medical education resources for students all around the world. Y'all have a great day.